Assalamu alaikum warahmatullahi wabarakatuh, guys. Welcome to the channel of summary of standard medical textbook. That is nothing but standard medical notes. Today we will discuss about a new cardinal manifestation of respiratory system, that is nothing but cyanosis. So let's begin with the name of Allah. So the topic is cyanosis. So what's the definition? Cyanosis is characterized by abnormal bluish discoloration of the skin and mucous membrane. Especially you should see nail beds, earlobes and earlobes and nail beds. It is caused by increased concentration of deoxygenated hemoglobin in the capillary blood more than 5 mg per deciliter, or presence of an abnormal hemoglobin, most commonly abnormal hemoglobin which is there is methemoglobin, and the concentration of that should be more than 0.5 mg per deciliter. Although cyanosis is often not seen until the blood saturation drops below 85% of room air. It is the absolute rather than relative quantity of reduced hemoglobin that is important in producing cyanosis. That's important point. It is not relative quantity of blood. It is absolute quantity of blood which is important for producing cyanosis. Example for these two are severe anemia, polycythemia. For example, patients with severe anemia and even marked arterial desaturation may not display cyanosis because hemoglobin is very less than 7 milligram per deciliter, and the hemoglobin quantity which is required for producing cyanosis is 5 milligram per deciliter. So how can severe anemia produce cyanosis? So it will mask the cyanosis. Severe anemia will mask the cyanosis. Conversely, the higher the total hemoglobin content, the greater is the tendency toward cyanosis. Okay, if the hemoglobin content is more, then less desaturation is required for producing cyanosis because quantity of blood is more, quantity of hemoglobin is more. So the patient will present with early cyanosis here. Conversely, the higher the total hemoglobin content, the greater is the tendency towards cyanosis. Thus, patients with marked polycythemia tend to be cyanotic at higher levels of saturation, means less desaturation, than patients with normal hematocrit values. Likewise, similarly, local passive congestion which causes an increase in the total quantity of reduced hemoglobin due to some obstruction like deep venous thrombosis. Okay, that is nothing but congestion, or suppose pulmonary embolism. So that causes local passive congestion of the blood. Congestion is nothing but uh, increased blood supply, increased blood accumulation in an area, that is congestion due to some obstruction in the venous pathway. So local passive congestion which causes an increase in the total quantity of reduced hemoglobin in the vessels in a given area may cause cyanosis. Example for this is DVT you can take. Okay, if in severe DVT you can have bluish discoloration of the limb involved. Okay, then cherry red appearance of cheek occurs in carbon monoxide poisoning, carboxy hemoglobin, which is nothing but in carbon monoxide poisoning. Okay, so here instead of having cyanosis, you will have cherry red discoloration of cheeks, cherry red discoloration. Okay, so what are the causes of cyanosis? Cause of central cyanosis. So central cyanosis is usually it is generalized and visible on the mucous membranes, mainly lips and skin will be usually warm. So it will be visible in central cyanosis mainly in lips and mucous membranes, and skin will be warm in the cases of central cyanosis. In patients with darker skin pigmentation, close evaluation of the nail beds, tongue, and mucous membranes is important because in those patients, bluish discoloration revealing a bluish discoloration of skin is difficult. That's why one should evaluate closely in these patients. So what are the causes of central cyanosis? So central cyanosis is generalized, and mucous membrane, mainly lips, or lips and mucous oral mucosa are mainly involved. And if central cyanosis progresses, then it can also have signs of peripheral cyanosis, meaning the distal areas will also stain blue if it becomes severe. Okay, and the skin is usually warm. So what is the causes? Number one cause is cardiorespiratory cause, nothing but hypoxemia. The saturation is usually less than 85% and partial pressure of oxygen is less than 16 millimeter of mercury. So what are the causes of hypoxemia then? High altitude, in the air only you are not having oxygen. Obstructive lung disease or pulmonary embolism. So this is respiratory cause. Pulmonary fibrosis, for example, interstitial lung disease. Okay, alveolar collapse. So these are all pulmonary causes. Or congenital cyanotic heart disease. Cyanotic heart disease, when there is right to left shunting, and pulmonary arteriovenous malformation. So these are the cardiorespiratory causes which cause cyanosis. So what are the mechanisms? Mechanisms are described here. Decreased partial pressure of oxygen in air in high altitudes. There is ventilation perfusion mismatch. In case of respiratory and vascular causes. What is VP? Ventilation perfusion mismatch. So here you have alveoli, here you have blood vessel, and this is the interstitium of the lung. This is alveoli, this is interstitium, and this is the blood vessel. So normally air comes, oxygen comes, and in the alveoli. So sometimes what happens, blood supply is normal, Q is normal, this is Q, this is V. Blood supply is normal, but that the blood supply to that area of lung does not have any air because of uh, no oxygen in the air itself, or because of some obstructive lung disease like COPD, asthma, or because of ARDS, acute respiratory distress syndrome, alveolar collapse. So alveoli are not receiving oxygen, but blood supply to that area is there. So that causes mismatch. So because of that, there is desaturation, or the ventilation is there, but blood supply is lost. Blood supply is lost to that area. For example, in pulmonary embolism. So that also causes VQ mismatch and produces desaturation. Now, both ventilation and perfusion are good, but the interstitium is fibrosed, so oxygen can't diffuse from alveoli to the blood vessels. So that's why in interstitial fibrosis you will have desaturation. Those are all the mechanisms. And in cases of cyanotic heart diseases, for example, in tetralogy of Fallot or patent ductus arteriosus, what will happen is, so initially there will be, for example, in ventricular septal defect, if you take ventricular septal defect, this is the atrium, okay, and these are the ventricles. This is the atrium, this is the ventricle. So when there is a large large ventricular septal defect, so normally because of strong left ventricle and high pressure left heart circulation, normally the blood flows from the left ventricular to the right ventricular. Okay, but still there is no cyanosis. This is known as acyanotic congenital heart disease. But over a period of time, what happens is, because of this volume overload, right ventricle will get hypertrophied. Right ventricle will get hypertrophied, and then there will be reverse flow of blood, meaning the deoxygenated blood from the right ventricle will flow towards the left ventricle, and left ventricle will pump a mixture of oxygenated and deoxygenated blood into aorta that produces cyanosis, and this reversal of blood is known as, this phenomenon is known as Eisenmenger syndrome. Eisenmenger syndrome. Okay, this phenomenon is known as Eisenmenger syndrome. So that is the mechanism behind cyanosis in congenital heart diseases. Okay. Similarly, in pulmonary arteriovenous malformation, so where there will be shifting of blood from venous to artery, that causes cyanosis. That was the first. So remember, these three are the main causes: cardiovascular and respiratory. 1, 2. Most common is respiratory, then cardiovascular. Third is presence of abnormal hemoglobin. These are the three most important common causes of cyanosis. So abnormal hemoglobin, like methemoglobinemia. What is methemoglobin? So normally in hemoglobin, the iron atom is in +2 state. When it is reduced to +3 state, then it is known as methemoglobin. And normally it is present in blood in 1 to 2% quantity, less than 1 to 2% quantity, and it is the bodies will not allow it to increase about that by some enzymatic mechanisms. But in some situations, the quantity of this methemoglobin will increase. For example, after exposure to some drugs like dapsone, sulfur drugs, dapsone. Okay, so the quantity of this will increase. So the main so this plus 3 iron atom has very low affinity to oxygen atoms. That's why there is low oxygen carrying to the whole body, and that produces cyanosis. Okay, that's the mechanism methemoglobin. It can be congenital due to some enzymatic defects, or it can be acquired due to exposure to some drugs. Okay, self hemoglobin is nothing but again due to use of some sulfur drugs. In these cases, when there is presence of hemoglobin, in these cases the partial pressure of oxygen is usually normal. SpO2, if you measure in these cases, it will be normal. Okay, moving forwards. So that was about central cyanosis and the causes of central cyanosis. Coming to peripheral cyanosis. So peripheral cyanosis is visible over the skin of distal body parts like fingers, fingernails, and toes, and nail beds. These, and sometimes ear pinna also. So there it was, skin was warm, but here the skin is usually cold. When present over the pinna, if you apply pressure, it will the bluish coloration will disappear. So this is important because there is something called as pseudocyanosis, staining from some drugs. So this point will help us to differentiate from that. Okay, so if you apply pressure to the pinna, that because the blood will move either, and there will be disappearance, transient disappearance of disappearance of bluish discolor, bluish blue color. Okay, so present in the skin of distal body parts, skin is usually cold, disappears when applied pressure to the pinna. And why it occurs, peripheral cyanosis? The cause is increased oxygen extraction from hemoglobin in the peripheral tissues. That is the cause. Okay, it is not because cardiorespiratory system is okay, but the blood is not pumped or pumped through the arteriovascular system properly. That's why the tissues are extracting from that only oxygen more and more, and thus the amount of deoxygenated hemoglobin will increase. That will produce cyanosis. So normally the arterial oxygen saturation is normal in the cases of peripheral cyanosis. So most common cause for peripheral cyanosis is nothing but cold exposure. So the your cold exposure will cause bluish discoloration, because why? There will be peripheral vasoconstriction. So because of vasoconstriction, blood uh, tissues will extract more oxygen from the available blood. That will cause bluish discoloration. That is the most common cause of peripheral cyanosis. So next pathological cause, most common, is decreased cardiac output, like in cardiogenic shock due to some reasons like some pericarditis, pericardial effusion, ventricular coronary artery disease, left ventricular failure acute. Okay, so that because of that there is less cardiac output and less blood flow to the peripheral tissues. So tissue will extract more oxygen, and this is cardiogenic shock. Then advanced heart failure and mitral or aortic stenosis. Again, in mitral stenosis you will have low ventricular filling, and in aortic stenosis ventricular filling will be there, but because there is obstruction to the outflow, the cardiac output will be less. Okay, so that's the second most pathological cause of peripheral cyanosis. Cardiac cause. Okay, remember cardiac cause. Next common cause are local abnormalities of the arterial circulation, like some atheroma in the distal arteries of the lower limb or upper limb, or arterial embolism from the heart. Okay, Burger disease, also known as seen in smokers, thromboangiitis obliterans. Name itself. So there is thrombosis because of inflammation of the artery that is causing occlusion. So why there is inflammation of the artery? Because of excessive smoking. So thromboangiitis obliterans can also produce cyanosis. And diabetic angiopathy, diabetic vasculopathy in diabetes patients. So these are other arterial. So local abnormalities of arterial circulation will cause cyanosis. Impaired venous drainage, as I explained. So thrombosis of some major vein, or post thrombotic syndrome, or in superficial venous system, superficial vein phlebitis causing vein occlusion, that also causes cyanosis. Okay, Other causes include vasomotor disturbances like in anxiety, Raynaud phenomenon, common seen in connective tissue disorders. So you will have the three color changes. No, first it will be pale, then it will become blue, then it will become pink. Three stages of the Raynaud phenomenon. And acrocyanosis, nothing but bluish discoloration of digits. Okay, so these are the causes of peripheral cyanosis: cold exposure, cardiac output, local abnormalities of artery circulation, impaired venous drainage, and vasomotor disturbances. Moving forwards. So one more, pseudocyanosis, false cyanosis. It is a rare phenomena. So this does not disappear with the application of pressure to the skin. So what is the cause? Abnormal pigmentation of the skin due to some drugs like CPZ injection, chloropromazine used in antipsychotic. It is an antipsychotic agent. Amiodarone, antiarrhythmic drug, can cause false staining. Minocycline, antibiotic, tetracycline class, given mainly in acne patients. Okay, acne, treatment of acne. So these agents can cause false discoloration. Or some metals, exposure to some metals like silver or gold, that is called as argyria, exposure to silver, chandi, sona. Okay, silver, argyria, and gold chrysiasis, that is called as chrysiasis. Exposure to gold and exposure to silver also causes staining. It is staining, it is not actual cyanosis, it is staining. So see here some pictures of central cyanosis and peripheral cyanosis. You can see here bluish discoloration of lips, tongue. Okay, here also the same central cyanosis, and you can see the nail beds are blue in this picture. So this is peripheral cyanosis. And remember, when the central cyanosis becomes severe, it will also cause peripheral cyanosis. So this is the summary of causes of cyanosis. Decreased arterial oxygenation, that is the most common cause, hypoxemia, either due to respiratory or cardiac cause. So high altitude, impaired pulmonary function like alveolar hypoventilation, or there is VQ mismatch, or impaired diffusion, fibrosis, or some shunts like congenital heart diseases, pulmonary arterial fistula, okay, or some abnormal hemoglobin like methemoglobin and carboxyhemoglobin, okay. Hemoglobin with low affinity for oxygen. So same thing here, hemoglobin abnormalities like methemoglobinemia, it can be hereditary or it can be acquired. Sulfhemoglobinemia, exposure to sulfur drugs like acquired. Carboxyhemoglobinemia. So it is not true cyanosis. Here the blood is also cherry red colored, and you can see some cherry red color in cheeks also. So okay, so that's about the cause of central cyanosis. Remember, as respiratory, cardiovascular, then abnormal hemoglobin. Basic. Then causes of peripheral cyanosis, you have learned, just it is a summary. So here, first he has kept, it is from Harrison actually, reduced cardiac output. Second is physiological cold exposure, redistribution of blood flow from extremities due to some AVM. Okay, arterial obstruction, venous obstruction that we have discussed. Now, how do you diagnose? How do you diagnose? So whenever a patient comes with acute cyanosis, remember, assess the stability of the patient. Mental status is the most important thing which by which you determine the severity clinically, by seeing only, by inspection only, severity of hypoxemia. Okay, so if the mental status is impaired, then maybe it can be due to severe hypoxemia, or maybe due to some acute and chronic disease, or some usually in acute state it will be mental state will be altered. So you should assess the mental status of the patient. You see the airway patency, any respiratory distress, and assess the vital signs: respiratory rate, pulse, blood pressure, body temperature is important, pulse oximetry, see the saturation. Okay, then focused history, which systems you will examine, which examination you will focus. You will focus on focus history, first history. First you should determine the timing of cyanosis, because if it is from by birth, then it can be some congenital heart disease. If it is not by birth, then it's likely to be some heart disease which is manifesting now, or it can be severe hypoxemia, okay, or some exposure. And you should focus on respiratory system, cardiovascular system, or exposure to some drugs or metals. This you should ask in history. In physical examination, see whether it is a central or peripheral cyanosis. So that those things use, if it is involving more the lips and mucous membranes, that is more likely lips and mucous membranes, and saturation is falling, that is more likely central. And if it is involving more of the peripheral sides and saturation is more likely it is peripheral cyanosis. Exclude cyanosis, how assess the respiratory and cardiovascular system. Okay, now you have done the emergency things, vitals you have assessed, mental status you have assessed, took history. Now you should perform an ABG or VBG, arterial blood gas analysis, or if not possible, you can do venous blood gas analysis also. Cyanosis, why you do this? To confirm hypoxemia. Why to confirm hypoxemia? Because cyanosis is not a reliable sign of hypoxemia. Cyanosis is not a reliable sign of hypoxemia, as we have seen that in severe anemic patient, there is severe hypoxemia, but those patient will not manifest with cyanosis. But in a patient where the hemoglobin is very much high in polycythemia, a low desaturation will only manifest with cyanosis. That's why you should confirm it with arterial blood gas analysis. Okay, and that is one thing why you should do ABG. Or then second is measurement of carboxyhemoglobin. Carboxyhemoglobin is due to exposure to carbon monoxide, like in fire exposure, like that. Normally carboxyhemoglobin is less than 3% in non-smokers, and if it is more than 3%, by if you measure by spectroscopy, then it is carbon monoxide poisoning. And if the percentage goes more than 20%, it is severe toxicity of carbon monoxide. And you should also measure the methemoglobin levels. Normally it is less than 1 to 2%. If it is more than that, more than, because it is more common, methemoglobin, if it is more than 0.5 milligram per deciliter, then it is methemoglobinemia. Okay, so you these things you will do. Then you connect oxygen, then assess the response to oxygen therapy. Why? Because response is poor in patients with cyanotic congenital heart disease, because the problem is not oxygenation, the problem is shunt. Okay, and in cases of significant pulmonary shunts of deoxygenated blood and pathological hemoglobin. So in cases of shunts, and in cases of abnormal hemoglobin, abnormal HB, oxygen therapy will show a poor response. So by that also you can have some idea about the cause of cyanosis moving forwards. So what investigations you will do? You will do a CBC. Sorry, you will do a CBC. Why? Because true cyanosis is masked in individuals with severe anemia, and cyanosis will manifest early in polycythemia vera. Then cause, pulmonary chest X-ray, pulmonary function test, required CT thorax, cardiovascular cause, ECG, 2D echo, and co-oximetry. Nothing but measuring different types of hemoglobin through spectroscopy you can do, and by that you can see which type of hemoglobin is different types of hemoglobin which are there in blood. Okay, and commonly you measure pathological hemoglobin. Most common pathological hemoglobin you will measure is methemoglobin. This is more common. Carbon monoxide poisoning is not actually cyanosis, cherry red it will be. So methemoglobin will be more common. So you will measure the levels of methemoglobin. So this is a key box. Just see this certain features which are important in arriving at the cause of cyanosis. So it is important to ascertain the time of onset of cyanosis. Cyanosis present since birth or infancy is usually due to congenital heart disease. Second, central and peripheral cyanosis must be differentiated. That is the next point you should do. These are the goals of our history examination and investigation. Evidence of disorders of the respiratory and cardiovascular system is helpful. Massage or gentle warming of the cyanotic extremity will increase peripheral blood flow and abolish peripheral, but not central cyanosis. That's how you. That's one more thing. How you can differentiate between central and peripheral cyanosis. Okay, so you gently massage or gentle warming of the extremity will abolish peripheral cyanosis, but not the central cyanosis. Okay, so you will differentiate between peripheral cyanosis and central cyanosis. Okay, and timing, and then presence or, this is also important, presence or absence of clubbing of digits should be ascertained. The combination of cyanosis and clubbing is frequent in patients with congenital heart disease and a right to left shunt, that is Eisenmenger syndrome, and is occasionally seen in patients with pulmonary disease such as lung abscess, yes, of course, pulmonary AVM, arteriovenous fistulae. In contrast, peripheral cyanosis are acutely developing. In contrast, this is also important. So clubbing with cyanosis, remember clubbing with C plus C. Clubbing with cyanosis is usually seen in congenital heart disease and in some lung disorders which cause clubbing like abscess, uh, fibrosis, subpurity lung disorders and malignant disorders and fibrotic disorders of the lung. Okay. In contrast, peripheral cyanosis or acutely developing central cyanosis is not associated with clubbed digits. Okay, that's important point. Chronic central cyanosis will also develop clubbing, but acutely developing central cyanosis, it will not have clubbing. Partial pressure of oxygen and oxygen measured by oximetry should be determined, and in patients with cyanosis in whom the mechanism is obscure, spectroscopic examination of the blood should be performed to look for abnormal types of hemoglobin. This is critical in the differential diagnosis of cyanosis. So ABG will also helpful because cyanosis is a not a reliable marker of this one hypoxemia. So along with that, ABG will also tell whether point towards some cause also. ABG will also help to point towards some cause, whereas as pulse oximetry just only it will show whether there is hypoxemia or not. So that will help in differentiating true or peripheral cyanosis, but it will not help in pointing to towards some cause. Okay. Now, how do you manage? How do you manage? Treat the primary cardiovascular or pulmonary cause. In acquired methemoglobinemia, like due to dapsone, benzocaine, prilocaine, sulfa drugs, primaquine, antimalarial drug, nitrates used in coronary heart disease patients. So these are very common drugs which we use, but these can cause methemoglobinemia. So stop the offending agent. And in severe cases, injection methylene blue will help because what it will do, it will convert Fe plus 3 to Fe plus 2. That's the thing. In carbon monoxide poisoning, usually in fire smoke, quit exposure, remove the patient from there and give high flow oxygen, so that the carbon monoxide which is attached to the iron molecule instead of oxygen molecule, that should be displaced from its point. So you give a high pressure oxygen in these patient, carbon monoxide patient. In severe cases, you will give hyperbaric oxygen therapy also, high pressure oxygen therapy, in order to displace that carbon monoxide atom from the iron atom. So mainly in carbon monoxide poisoning, the pathology is, so oxygen is bound to iron molecule. So in each hemoglobin molecule, there are 4 iron molecules. Okay, so each hemoglobin carry 4 oxygen atoms. So the main thing is there will be competition between this oxygen molecule and carbon monoxide molecule atoms. Okay, so this carbon monoxide has very high affinity, very high affinity when compared to oxygen molecule to the hemoglobin. That's why it will displace oxygen very easily and it will go and attach itself to iron. So there is no oxygen and there will be cyanosis. So to get rid of this, to for treatment purpose, what we do is we give a very high, some high pressure oxygen, so that the carbon monoxide molecule is displaced from iron and oxygen is attached. That's how we treat carbon monoxide poisoning. That's about the topic of cyanosis. So thank you for listening, and do comment if any correction is required. We'll do that. Thank you.